So moving on to our next session, our second session is on the future of cancer care and finance in India. A study revealed that among non-communicable diseases, cancer has the highest probability of resulting into a catastrophic expenditure for a household. We look forward to knowing our experts' views on the future of cancer care in India. Our speakers are highly successful doctors who have years of experience and knowledge when it comes to dealing with various forms of cancer. Joining us at this panel are Dr. Ashok Mehta, Senior Cancer Surgeon, Max Nanavati Hospital, Mumbai. Mr. John Chandy, Chief Business Officer, Apollo Hospitals Oncology Group. Dr. Padmaja Lokireddy, Haemato Oncologist and Bone Marrow Transplant Consultant, Apollo Hospitals, Jubilee Hills, Hyderabad. This session is going to be moderated by Dr. Mohan Menon, Medical Oncologist, Lilavati Hospital and Research Center. Dr. Sandeep Nayak, Director of Surgical Oncology, Fortis Cancer Institute, was also supposed to join us, but he had surgery, which is why he could not make it. But I'm sure this discussion is going to be equally enlightening as the previous discussion. So over to you, Dr. Mohan.
Hi, good afternoon. As was mentioned by Mr. Tripathi, I'm a medical oncologist in Mumbai. And this is a topic that is quite dear to my heart. This is as predicted by the WHO about a couple of decades ago. We are seeing a dramatic increase in the number of cancer patients that we are seeing all over the world. But this increase is particularly so in the third world. And having a large population like we do in India, we are seeing an explosion in the number of cases. Now, getting resources to treat all these patients is quite a difficult issue. And as was mentioned in the previous talk, it is something where all the stakeholders have to come through. And hopefully together we should be able to do a better job of treating all these patients. Now, the way we plan to do it is to...
Hello.
Yes.
Hello. I am unable to start my video. You're not enabling me to start the video.
Take a look into that.
Now it's started. Yeah.
All right.
Okay. Yeah.
So, as I was saying, finding the resources to give appropriate treatment to all these patients is going to be a challenging task, and that is something that we have to look into. And the treatment of cancer occurs over a long period of time. And during this period, if there are no access to other resources, families have to pretty much dig into their savings and then subsequently sell stuff in order to take care of their loved ones. And it is no surprise that the most common reason why families go into penury is actually chronic diseases, and cancer is one of the leading issues. So we'll start off our conversation. We'll certainly miss Dr. Naik, but I'm sure my other panelists will do an able job with that. And so the first question has to do with the issue of predicting the cost of cancer treatment. Because unless we give the patients a clear idea as to how much something is going to cost, some particular treatment is going to cost, it's going to be harder for them to come up with the resources. So the first question to Dr. Ashok Mehta is, how can we make the cost of cancer treatment more predictable?
Okay. I think it is very important that when a patient comes to us, he wants to know the cost of the treatment. And the cost of the treatment would, of course, depend on the type of room that he chooses or the hospital he chooses to go. because many of the hospitals have the packages for the cancer patients. But some of the hospitals, they are like a la carte, whatever you treat or whatever you use, they bill you for that. And of course, then there are insurance companies which take care of the cost of the treatment. But as far as the patient is concerned, if he is supposed to pay by himself, then the question is that we have to really work it out in a proper, appropriate way. As a surgeon, normally I try to help them as much as possible by charging the minimum fee, or and put them in the appropriate ward, so they don't spend more than what they have planned. But you need to give them some kind of a treatment. Nowadays, most of the hospitals, especially the corporate hospitals, they have a department which gives them all the breakup of the cost of the treatment. Because I think some of the hospitals even ask them to deposit the whole amount beforehand. So I think that depends on the type of surgery that you're doing, the time that you're going to take, as well as the operating fees as decided by their particular hospital.
So the estimation department helps with that.
Yeah.
Dr. Mr. Chandy, do you have anything from your perspective?
See, in my perspective, if you look at the cancer management in India, it's predominantly currently, except few hospitals in Delhi and Mumbai, if you look at it, is in the corporate or private segment. That is the biggest factor I am feeling for how to, when we come to predictability comes. So even though there are some Arogyasri schemes at the government level, they are not able to address the right needs for the patients. So we need to really see what's the level of insurance, how they pay. Many of them pay cash. They sell the property, or they even sell the cattle and bring for the treatment. They don't know what is the end results. So correct and early diagnosis of cancer, comprehensive approach, value-based medicine. That is wherever we need this fundamental, we need to strong operate. An ethical approach and assured pricing. Assured pricing is the main thing when you come to estimate, when a patient comes in. Most of the time, many hospitals today give a comprehensive overview. What is the total? I've come to a surgeon. This is the cost. Don't talk about the surgery. What is the post-treatment? Overall, what is the cost? If we give them a comprehensive cost in the next 1 year plan, that will help them to predict the cost of the treatment.
So what we're saying is that we would like to have more packages. And, we would like to have the schemes that people are being covered with.
Schemes. I don't say schemes. I say more of scale. If you want, how the cost will come down if you do more value-based package. For a similar, we are doing more thyroid packages. How a the corporate hospital can bring down the cost. If a doctor can say, look, if you give me at 5 lakhs, I can get you 20 patients a month. So basically, this is basically the game, volume game. So if you can work on the volumes, you can tweak the price.
Sure. Question for Dr. Lokireddy. Now, we heard from the surgeon, we heard from the radiation oncology people. Are there differences in how well we can predict the total cost of care amongst different specialties? And you're into bone marrow transplants, medical oncology. So do the previous statements that were made, do they apply to you, or do you feel differently?
Thank you, Dr. Menon. It's a very valid question you asked. What we've discussed about surgical radiation packages can be done as things are predictable. Suppose in hemato-oncology, as we see, the cost of therapy for chemotherapy is very little, and there is no surgery involved. So it's more of an intensive care type of a approach, and it's day-to-day changing. A patient could be stable all throughout. It's a month of a treatment inpatient where he's sailing through between a life and death in a leukemia patient. So it is a little bit difficult to predict for each patient, but broadly speaking, we could categorize them into a low risk, medium risk, and a high risk groups and give them a rough possible estimates. with a catch that they could hit an ICU for anybody and the cost could be phenomenally different. Or if they hit a fungal infection, those are the two biggest things where the cost will just go up. And the package is what you could say a possible approximation for the different age groups, the low, medium, or a high risk, could all depend on where you're treating that patient, because a lot of this treatment cost is on a day-to-day basis, a quality service and the expertise what the people show on a day-to-day basis. Because if you say take a leukemia treatment, the cost of a leukemia drugs have not changed significantly, and the cost of the leukemia treatment is very minimal. It's all about the supportive care, and there is no bar for the supportive care. Supportive care can range from X to Z, so it's quite variable about the quality and what the patient would want. So it is a lot more an individualized approach when you're giving a quote for that patient, what is affordable, what services he could go for, and what is his expectations. So based on all that, you have to give a quotes and possible quotes. We cannot definitely predict for those patients. Transplant, again, in a similar field, for auto transplant, you give a rough estimate for allo and haplo. Some transplants are low risk. It can be delivered with a risk-taking behavior. But when we're doing a high-risk transplants, when you put a code, patient is going to sit on it. So it's difficult. And your hands are tied to deliver the best quality of care, where you need to escalate. So in certain fields, it can be a bit difficult to make packages. Though we give a rough estimates, they're only just an overview for a patient who sails through in a standard way.
So patients who, are going through medical oncology or transplant services are, as a group, a sicker group of patients. So because they are a sicker group of patients, there is more unpredictability in what can happen. The patient may sail through treatment where it would be, as you said, a low-risk patient. And in that situation, great, you save a lot of money. But if it's somebody, and this happens to most of our patients, they tend to be a higher risk group. And there all bets are off, and the patient may get admitted to the hospital, may have, as you said, infections or fungal infections. And in that situation, it's very hard to give a handle on how much things are going to cost. Am I right? Okay.
Yeah, overall, definitely we can predict to some extent, but there is
it's harder to do so.
Differences. Yeah.
Our next set of questions have to do with healthcare insurance, which is in the news all the time. And one of the things about a country like India with 1.3 billion people is that there's a lot of people to spread the risk. That means, cancer, despite the fact that we have a lot of cancer in India, it is comparatively a rare disease. So if you can spread the cost amongst a larger group of people, theoretically, you could bring down the cost and you could de-risk people. However, the problem is that a lot of the coverage that exists is not, as was mentioned previously, tailored to certain situations which we commonly face in cancer. And I start the question by asking Dr. Ashok Mehta, what is your perception as far as getting healthcare coverage in India? And I'll roll in the next question, which is the issue of.
Can you talk a little loudly? I can't hear you properly.
Sure. So the question, sir, was healthcare insurance.
Yeah.
As well as what role is the government playing as far as coverage of the general population for cancer is concerned?
Well, health, the people who give the healthcare insurance companies, sometimes they are also very difficult to handle, because they show you everything will be paid off, and when it comes to really accepting, they start cutting the costs. Then they'll say we'll give you 15% less and things like that, and the patient is at the mercy of those people, and many times they refuse to cover the amount upfront. In other words, they'll say, okay, we'll give only a part of it and not the whole of it. So I think this is where the main problem starts. And many times the hospitals will ask patient to pay first and then get it reimbursed. So I think the handling of the insurance company by the hospital staff is very, very, very important. Recently only I had a patient who was fixed for a surgery, and then they said, okay, we pay 15% less. So the hospital said that we'll charge 15% more to the patient. I said, no, that's not proper. We'll reduce our fees by 15% if necessary. But this is how it works out. So I think insurance companies in our country, their reliability index, in my opinion, is much lower than one would expect them to be.
Mr. Chandy, what difficulties do we face in getting insurance coverage for cancer treatments, especially proton beam therapy?
Also, I'd like to add one more thing. I treat a lot of patients with head and neck cancers, especially mouth cancers. For every patient, they ask, what is the cost for cancer? And if you tell them that the guy is a tobacco chewer or smoker, is rejected straight away. I think it's ridiculous that patients who suffer from oral cancer, or for that matter, if a man has got a cancer of the lung, and if you ask him, are you a smoker? And if he's a smoker, you reject, that's not acceptable.
Very true. Very true. Go on. Thank you, sir.
Yeah. Dr. Mohan, actually, if you look at the insurance segment in India, almost 7 years back only, we from Apollo took the initiative to start the first cancer protection plan with Apollo Munich. Thereafter, today, thanks to the initiative, there are 10 companies offering cancer protection plan as a part of their insurance package. Still, it is very little to do. The number of patients who are having protection are far below, is less than 3%. Many of them are in the segment of group insurance cover. Good thing is that in group insurance cover, there is no pre-illness are fully covered. There is no exclusions. When you go for individual cover, there is exclusions for at least 180 to 180 months or up to 1 year. There is an exclusion period. Many of the patient does not aware of it. They sign it without reading the terms and conditions. That is the important thing we all need to take care. Second thing is the coverage of the limit in the group insurance cover is fairly decent. It depends upon where you work. So they have a better cover. So you're able to cover. Normally, if you look at the cancer patient journey, and first treatment cost, surgery with chemo radiation, it'd be easily 10 lakhs rupees. So this 10 lakhs in a corporate hospital can be covered if someone has a good insurance cover. Otherwise, they have to use a multiple option insurance plus self-paying option.
So the next question is for Dr. Lokireddy. How can we broaden the coverage for insurance for more treatment options for cancer?
So before we talk about broadening the insurance coverage, I think it's a very valid point for everybody, for all of us to say is people should think about a health insurance. An insurance of 1 to 2 lakhs is just not enough, where the expectations of people have risen to a significant extent. Our Indian population want a specialist consultation on the same day, investigations on the same day. So our expectations from people have risen way far from the West. And again, we have to raise the awareness. Cancer treatments can be made cheaper. Insurance can be broadened, but they have to plan for their future. Can't just rely on the government. How do we broaden? Once they take up an insurance, it has to be a good amount of insurance to cover the cancer care. So cancer care is expensive when we're looking at world-class treatments now available in India. And once there is, in a lot of insurances, there is, if they don't claim, there is going to be a doubling up service, which could be taken up. But once they're diagnosed cancer, it's not just the insurance. They can take a combination of the rest of the things. Yes, the insurance will pay some. They may have to pay some from their pocket, and they have to look at other charitable, like how, fundraising, crowdfunding, all these. Otherwise, some treatments are just enough to fund from their insurance or a bit from their personal pocket. But the cancer treatments with bone marrow transplant, leukemias with a lot of new immunotherapies, the new advanced thing like CAR T cell therapy, no person can just fund it themselves. So we need to have a combination of these things. And one thing, people have to shy away from going for a crowdfunding. We have to raise the awareness. In our personal experience, what we see is the middle class people or a lower middle class are the ones who don't go for a crowdfunding, or the higher educated or people who are accepting crowdfunding? Actually, in fact, the middle class are the ones who need it the most. So I think raising that awareness, taking that shame out of crowdfunding, and it's quite an easy thing, and thinking about for future plan and broadening this personal insurance and a charitable or a crowdfunding ways. But if it is a government insurance like Aragyashri, it is just not going to be enough. Or EHS, it may not just be enough, but can the patient pay part of it? Because now existing EHS will not allow patients to pay for. It will penalize the hospitals if we tell them to pay for anything. But there should be a dialogue from these services to say that actual fact, this is the right treatment I need to get, but how much you can fund it. And if you're clear about it, rest, whether I will be able to afford to fund it or not, or either they go for crowdfunding. I think patients should have that information up front, and they can make a valid choice how much is given by their government service, and the rest, how can they fund it, and is it they can fund it or not. I think that patient information about this and openness and taking that shame away from crowdfunding and using all these for the best patient care is the paramount. Thank you.
So I have the next question, which is what option? What are the major costs to delivering care? One second. Okay. What are the major costs to delivering care, which is for Dr. Ashok Mehta?
I didn't get your question.
Costs, where the costs are for delivering cancer care.
I can't get your question.
Yeah, hold on. The question is about delivering cancer care.
I think there is an echo coming from Dr. Mohan. I'll repeat the question. I believe he was asking was, where are the major costs to deliver cancer treatment in India? Where are the costs involved?
I think a lot of cancer patients receive, I would say, the treatment which is recommended by the NCN in America. As a matter of fact, I am one who tries to tailor the treatment to the patient's need. In other words, some of the patients who are operated, they don't need radiation and chemotherapy. If you label every patient as a high risk and then start treatment with both radiation and chemo, that increases your total cost. So I think tailoring the need of subsequent treatment is equally important. And one of the things which we normally do is we have lots of charitable trusts on our list. So my secretary takes care of the patients who can't afford. We refer to those charitable trusts, but then they have to go to a number of trusts. It cannot be only one trust which can subsidize. So I think it has to be a multi-pronged attack. You reduce the cost both in the hospitals. You can reduce the cost is by way of, if you are going to have institutions which have lower rates, and that only can be done if you are in control of the institution. Like I was a director of a municipal general hospital, which was a private public enterprise, and there we had kept the costs very low, especially for those patients who are economically lower class. We would give them economic treatment with a fixed budget. For example, that major operation, supra-major operation would not cost more than 20,000 rupees. So that kind of arrangements one has to make. And that brings us that how do we reduce the cost of treatment in our country? That is possible if you have hospitals which are built by the either corporations or by governments, and then they are handed over to specialist groups who can run these hospitals more economically and more in a business-like fashion, because that is only possible. The cost of treatment goes up because of the cost of the land and the cost of the buildings. Now, if those things can be subsidized, in other words, if they are given to the professional groups, say for example, a cancer hospital is built and handed over for running to a group of people or a trust or even private enterprise, that would reduce the cost remarkably. I think that's one of the things which should be looked at very critically, because whatever number of cancer hospitals we build, the number of patients is bound to keep on outstripping the what we create, and therefore I think we have to create them in a short span of time, and that is possible if we start this what we call a PP, private-public enterprise.
Yeah, yeah. So I think the major costs are, as you said, the land for the location, the radiation machines, the surgical tools, and of course the people who you have to hire on an ongoing basis. These seem to be the major areas. And I think another thing that sometimes comes up is that you have to change your machinery every 5 years or so. That's basically the life cycle costs that you end up with. So those sort of costs are the main thing as far as I understand. Am I right, Dr. Mehta?
Yeah, and, I think the high-tech things cost you more. For example, linear accelerators, they go 15 to 20 crores. Then if you're going to have all these fancy scans, PET scan is a basic, that cost keeps on increasing. So this should be brought within a reasonable limit. For example, even the government can create institutions where these are subsidized. In other words, CT scans, MRI, and PET scans, if they're subsidized, then the cost will come down remarkably. Because I think those investigations are pretty expensive. A patient spends 15,000, 20,000 rupees or maybe 30,000 rupees on investigations. That should be reduced relatively.
And I think the cost of importing, a lot of machinery is quite high in terms of custom duties and things like that. So those all add to the cost of the treatment that you may have. I mean, if you want to do justice to your patient in terms of treatment, you do need some of these scans. And, it brings up the concept of appropriate technology. That means, we don't want technology that is being done without use. But at the same time, certain things, you do need to deal with. And we'll deal with that question subsequently. You've already answered my next question, which is, how can we reduce the cost of cancer treatment, Dr. Mehta? I will turn that question over to... I'll turn over that question to Dr. Lokireddy. That is the question of how can we reduce the cost of cancer treatment for our patients?
So certainly a very valid point of public-private partnerships, which we have already discussed. Again, when we come to reducing the cost of therapy, that the tag goes along with without reducing the quality of care. And again, the word comes back, what is the bar for the quality of care, what you're expecting? It is about the patient expectations, the quality of care. Suppose if you look at globally, there are certain expectations in each country. Like NHS, the NICE looks at cost effectiveness for any particular drug. If we're talking about, medical oncology or hemonc, and NICE says that if you spend this much money for treating this many patients, yes, it's cost effective. You use it, they would authorize it. That drug could be funded by FDA, but it could not be funded in the National Health Service in NHS because NICE disapproves. It doesn't mean that doesn't work, but it works for only small group. So you don't want to waste money. But that concept, is it valid for a patient who is paying from his pocket? So the cost effectiveness comes when it is a public funded service. But here in India, we have a public funded, private funded. So one thing doesn't fit all. So if a patient coming to a corporate hospital, the information has to be given to him on a broader level at each, and he makes a choice whether that treatment, how much the cost he spends, and the time he gets, whether it's a cure or spending few more months, is it effective and worth for his money? He needs to make a choice. We're not here to make a choice. That's something, it's because it's a variable spectrum of patients we're seeing. And a lot more, because I've worked in NHS. NHS practice is much easier. It's guidelines. Somebody decided this is the bar and you just go on that. But here, patient has got a variable and you don't know just by seeing that patient whether he can afford it or not. So it's a lot more planning and knowing the patient expectations and talking about the holistic cost of the treatment and seeing where he fits into and accepting that risk if he cannot afford that. And in that given patient, how do we reduce the cost? Yes, certain treatments can be delivered as an outpatient with a closer follow-up. And again, how much distance he stays in. Can this patient be as a partner of a public-private? Currently, we have no scheme where the government and the corporate work together. Either we accept or we don't accept. So like leukemia, all my discussions come from leukemia and transplant and the high-end care. So we cannot take Arogyasri patient and use that amount and ask him to pay. So it's about the expectations, planning, and what is the quality of care that particular patient asking for. Suppose there are so many new tests, genetic tests are available now in leukemia, they're not going to confirm the diagnosis. We've already got the diagnosis. All this is just to give a prognostic benefit. And before we make the patient spend, we're going to ask whether that information is going to make a difference, or it may not make a difference, but patient has got money and he wants to know the information. So it's all about that personalized individual care. And of course, looking at reducing the cost for that particular one. And in broad essence, certainly it's about without compromising the quality, we want to reduce the cost, be it from the hospitals, the service oriented or the partnerships, and what is the expectations and how we can deliver. Yeah. Thank you.
So I guess the point is this, that yes, there are guidelines as far as what treatments we can give. That means a particular disease can be treated with X, Y, or Z. But in a place like India, where things are heterogeneous and very dependent on the financial situation, whether it's through insurance or whether it's through the patient himself or herself paying, it's hard to sort of generalize and say, this is how we will do things. I'm assuming that's what you're saying. And, I mean, it's a fair thing. I think that's the world we live in, and that's what we have to work with. And I think the question also comes up as to where do you limit care? That's a little bit off script in this situation, which is probably something I'll ask after this. I think, Mr. Chandy, do you have anything to say on this particular issue of how can we reduce the cost of cancer treatment?
Today, if you look at, the government has to really come up and say how we are going to handle the burden of cancer. Cancer earlier was almost taken as like a old age disease or a death sentence. It's changed today. So the PPP projects, reducing the custom duty, even the participation from tech companies, even pharma companies may even bring the cost down. So the major cost in a cancer hospital is, one is an OPEX, other one is a CAPEX. How we can bring this both costs down? This can be done only with the private equity participation. It's not only from hospital to government, even the industry also should come forward.
Sure. Now, the next question is, we talked a lot about reducing the cost of care. But, in the process of reducing cost of care, are you really, delivering an optimal response? That means, how do you balance between the quality and the cost of care? Ideally, you want the best quality at the lowest cost, but that's a difficult thing to do. And I can start with you, Mr. Chandy. You want to take that, and then I'll ask the other panelists also.
If I worked in US, if you look at the CAPEX cost in US, it's almost same like India. But if you look at the treatment cost, it's almost 1/4 of US. That's this is the major challenge we are facing. Capex cost is almost same, but when it comes to treatment, reimbursement of treatment costs is 1/4. You see any treatment you take, like the surgery, medical, or radiation you take, or a diagnostic test. Because of that, what we think is India should focus more on volume games. We need to talk about how we can increase the volume without affecting quality. Choosing the right treatment, right case for the treatment. Let it be curative or palliative, be informative and do the right care for the patient. I think these are the few suggestions I can put forward.
What about you, Dr. Lokireddy? Do you have any thoughts on this issue of
I echoed
balancing?
I echo Mr. Chandy's thoughts. Just one more thing, maybe a single specialty oriented approaches, disease specific. So you can rationalize things and streamline in that way, like playing volume games. If you've got a single specialty and disease oriented clinics, that may be easier to work and formulate the processes and to liaison with the partnerships and industry and government. Yeah.
So
what industry wants is data. Data is a gold mine.
Yes.
Every industry comes forward to India to say, if I give this data, especially in medical oncology or hemato-oncology, they want data. Data is a gold mine.
Unless we do a single specialty related, it becomes tough. Yeah, sure.
You see the data, Dr. Lokireddy knows the patients we see in India versus in US. We do 3x every year than US.
Volume-wise, you mean?
Yes, volume-wise.
So I think we can probably use that as a source of revenue. That is anonymized data, which is of large volumes, which is something that we can potentially provide here, provided there are good takers and, provided the data is appropriately scrubbed to be anonymous, can be a source of revenue in order to subsidize some of the treatments that are being given. I mean, I think that's the point that is being made, right? Okay.
Last thing is the research.
What about you, Dr.
Sorry to add, last is research and trial. If we can add this, it will get enormous support from the industry. That's where the cost can come down without impacting the quality.
Sure. So that's another source of revenue, or that's another source of trying to provide newer treatments for a larger group of patients, provided the culture of clinical trials seeps into an organization. And that's a different thing altogether. Not every organization can do it, but it's certainly a worthwhile thought. What about you, Dr. Mehta? Do you have any thoughts on the issue of how can we achieve this ideal balance between quality and cost of cancer care?
Delivering cancer treatment I have been in practice for last more than 50 years, and I have seen the costs going up like this. The reason is that I think lots of newer treatments are being introduced. Lots of investigations are being introduced continuously. And you want to improve the quality of treatment and quality of care, you'll have to keep increasing, look at the possibility that the cost is going to increase. Now, next is going to be a targeted therapies. They are going to be exorbitant expensive. And not only that, but even to investigate whether the patient should receive a targeted therapy or not, it's also going to be expensive. And therefore, I think the cost control is going to be difficult. And then our successive governments, or they make these popular announcements for free treatment for all. And then they have an insurance which is a very basic, which cannot cover the costs of treatment. For example, in Maharashtra, the cost of cancer patient treatment is maximum 120,000 rupees. Now, what do you get in 120,000 rupees? I don't know, what do they expect the people to do? And you cannot charge them. You have to pay even for the traveling. You have to take photographs of everything, patient on the table of the specimen, ridiculous things. They can't understand the basics. They are running like administrations. You cannot administer this kind of a treatment by making these silly rules. And if you don't have a trust, you cannot run the business. Treatment of cancer has at multiple levels. It cannot be standardized by saying that 120,000 rupees or whatever. It cannot, you know, you have
There's no
to
magic you can do with 120,000 rupees.
we have
No,
now
I understand.
cancer grid, which are going to standardize the treatment. But that standard also will vary from institution to institution, city to city. It cannot be the same. The cost of treatment in a city like Mumbai is bound to be expensive. I'm sure the same thing holds true for Delhi or other cities also, because the cost of the properties are very high. And unless until you have a good hospitals which are built, the newer hospitals built with the newer technologies, you can't expect the treatment
The
to
standard
be
of care.
lowering the cost. Yes. So the answer to this is the private-public partnership is absolute mandatory, and it cannot be taking over a period of years. It has to be done quickly. Hospitals have to be built as per requirement and given over to the groups who can run it. I think this is the way lots of other countries have done in the relatively poor countries.
True.
As a matter of fact, India is, as somebody mentioned, this is the cheapest country for treatment. Lots of our doctors who we train them for 5 and 10 years, and they walk away from here because their cost, you know, they cannot even buy a house or they cannot look after their family. And therefore, it's very important that we don't lose our talent. This talent you cannot equate with costing. You know.
So I know. I think there's another factor
free
also.
housing, support their education or something is very necessary.
True. So yeah, I mean, the help that we get has to be more practically oriented and has to be given in such a way that it is beneficial to patients rather than just existing on paper. Another factor which I think I should also mention is the fact that it's a good thing actually why the cost goes up, which is the effectiveness of the treatment. When I started practice in 2001, the average myeloma patient would live probably for a year, maybe a year and a half if you got a bone marrow transplant done. And now people live for 6 years, 7 years, and that has to do, it's a testament of the effectiveness of the treatment that we give. So the longer the person lives, the more expensive the treatment is going to be, from a quantitative perspective. And also from a qualitative perspective, what ends up happening is that, you use, as you said, Dr. Mehta, that newer treatments are going to cost more. And especially if you're paying in dollars, it's going to cost you more, definitely. This is the last segment of questions, which is a lot of times families are forced to deal with a sudden event. That means a diagnosis of cancer, a breast lump, or colon cancer, or a head and neck cancer. And suddenly they have to come up with a large amount of money to pay. Now, if we could sort of spread that cost over time, we talked about spreading the cost over a larger group of people, which is insurance. Now, spreading the cost over a larger period of time, that is amortizing and spreading the cost, that would be another way to sort of make available treatments for a larger group of people. Now, this was a question actually for Dr. Sandeep Nayak, and I liked his answer previously from it, but I will leave it to any of my panelists to answer this question. That is, spreading the cost over a period of time for the cancer treatment. How would one play a role? And a question like, Impact Guru and so on and so forth. How does that play a role in a situation like this, where you can spread the cost over both a larger group of people as well as over a larger period of time?
I have heard of some people, they used to come to our hospital in Mumbai and they would give the loans, unsecured loan. But I have no particular experience on this.
It's still in the infancy, and it's done more as on an individual basis, on the basis of trust. rather than, in a standardized manner. That means there's no process to doing things like this, but it's certainly something, it's a novel approach that we can
actually
look at.
just to add it. Now, Bajaj has come out with a EMI scheme for patients who has come with a sudden illness. So up to 10 lakhs, if you are able to show the repayment, the family can show the repayment model, they can give 5 years, 10 lakhs. And with a standard interest rate.
So it's a loan.
Yes.
So what sort of interest rate do they typically
They're talking
charge?
about 9.5%.
Okay,
Still
so it's
lower.
kind of like a home loan type of a thing.
Home loan type thing, but it's secure. They're not secured, but they'll basically get a posted checks and they'll do the validation within. By morning you apply, by evening we know whether it's approved or not. So you get, and this money is not paid in lump sum, money paid to the treatment.
This is being advertised as well in the hospitals about 2 years ago, but it didn't actually take a lot of, whether there was difficulties in people getting acceptance because they're coming from a different state or they're coming from far, and the surety was an issue. But it is certainly a good one. Yeah.
Anytime what happened is, for example, a patient has come from Guwahati to Hyderabad. When you do the validation address proof check, all will not get passed through immediately. They do the basic, the SOPs are meant for the same city. So they come from Guwahati, so that it's not getting matched. That's why getting rejected.
So to be honest, it didn't take somehow the popularity, though it looked a very good option for patients. It didn't take for various reasons.
Something which you can think about it and see whether it's worth revisiting.
Yes.
Second thing is that many of the one of the two pharma companies came out with the patient support programs. They say that this particular drug, the patient can enroll into the trials. They're able to support the program. For example, 40 lakhs or 50 lakhs drugs, they're able to bring down the cost.
I think one of the important things that one should really look at is support for the patients who cannot afford, or from the religious trusts. There are religious trusts who got hundreds of crores. I think we should, as a group, try and involve them for supporting these kind of patients, where they can give them as a loan without interest, because those monies are to be used for charitable purposes. I think somebody has to work on it, and honest work, rather than, it's not a...
If I may add the last thing, yes, all this private insurance, charitable, why not a government have it? Somebody is willing to pay it back. They're not asking for free. So this would be, nobody wants to take a risk, and somebody comes with a vulnerable position. You're asking them to put in your, whatever the things, it becomes tough. And so if there was a government schemes involved into it, where patients are going to pay for it later, they're not getting it free. And I think more and more government should roll into such kind of programs. So people are not, there are a big group of people who don't need a free treatment, as long as they're given an option to pay it back over a period of time. That gives them a responsibility in their care and the long-term follow-up. A lot of patients who get a free treatment, they're done and dusted in the first few months. They're not continuing with the long-term follow-ups. The relapses are not recognized early. So there is some amount of commitment from the patient is necessary. I think that will help. Thank you.
I think for curable diseases, that's a great idea. That means, you have an early stage breast cancer or a Hodgkin's lymphoma. I think, the person is alive at the end of the whole thing. And so, if you loan some money to that patient,
good prognostic.
Yes, you might potentially be able to do that. Harder to do with an incurable disease, because, who's going to take the loan, who in the family is going to take a loan, and those things are delicate, and those things would have to be worked out. There is some precedent in the microfinance world where, the loan's not taken by an individual, but by a group of people. And so what happens is that if you have a group of people taking on risk, there's a better possibility that you might be able to get a loan that works under those circumstances. But, thoughts for, the future in terms of what we can do in terms of helping patients. Now, I think we're getting close to the end. We have another 8 to 10 minutes. Any closing thoughts, Dr. Mehta and my other panelists?
I very strongly feel that the answer to our problems of number of cancer patients and the late stages in which we see is, of course, an early diagnosis. But that also is a dream because early diagnosis also costs. Because you must go every year for a checkup, and it's going to cost you maybe a few thousands, maybe 5,000. But most of the people do not want to put in that kind of money for early diagnosis. That's one thing. But I have a feeling that those Medicity projects, which I have heard about, where they produce buildings 5 or 10 specialties together in a campus, which would be owned by the state government or a central government or by a corporation, and is given over to the medical experts to run. That is only way of reducing the cost. There is no other way. When we talk about government schemes, if they have a scheme and they have very little payment, like central government health scheme, they hardly pay anything, and nobody would be interested in undertaking treatment of these patients. There's so much of documentation they want, and everything is upside down. And sometimes they don't pay even for many years. So I think those are the areas where there has to be improvement. There has to be some kind of serious looking into it, that all these schemes which are already in existence, but they are not able to help larger number of people because of some inadequacies in terms of payment or in terms of procedures. I think they have to be revisited, and somebody has to have a serious thought to it, how we can make them more effective. Having a scheme is very simple, but to make it effective is going to be more difficult.
Sure. Mr. Chandy?
First of all, I would like to thank Piyush and team for taking this initiative to organize this program. Congratulations, it's a good way, because there is a lot of myth about crowdfunding. This type of initiation will bring enlighten the patient and the caregivers. What is it? So I'm borrowing the money, should I pay back? This awareness actually really need to grow. That will help, especially for managing cancer. Second thing is that still about the cancer management, awareness to the public in the government level and NGO level has to grow. Then the early detection start growing. Many times there's a lot of myth, they are very scared, they try to hide the disease. So we need to do in the government level, at various levels, how to bring early screening, early detection should be the mantra to conquer the cancer disease.
And Dr. Lokireddy?
I think we've covered most of them about partnerships, early detection. And my key thing is without compromising the quality, we reduce the cost. Because in India, worldwide, if you look at, the cost is already low. We don't want to put down and then reduce the quality and hamper the new progress of the new treatments, what we were able to get. So I think it's kind of a balance. We shouldn't just talk about reducing the cost. How do we get the best quality for a larger number of patients by partnerships with a given good information and a good infrastructure with a structural approach? Even the patient getting a free treatment has a right to know the information, what is the best, what he gets, and where else he gets the rest of the treatment funded and move further.
Great. I will sum up the discussion, and if there are questions at the end of it, I think we still have a little bit of time to answer them. I'll start by saying that, cancer treatment has improved dramatically over the last couple of decades. It's very effective, but it is also very expensive. A lot of our patients have difficulty in finding funds to get treated appropriately. This is despite the fact that India, the costs of treatments are quite low. However, if you want to get something from abroad, it is going to cost you a lot. As was mentioned earlier, the capex is high, but the treatment cost, what you can get for it is low. We do have large volumes of people. We are blessed with a huge population. And that, in theory, should reduce the risk for companies because you're spreading it out over a larger group of people. So an imaginative use of insurance schemes, as well as novel methods, such as what we said about public-private partnerships, in order to provide the infrastructure at a lower cost so that the running costs can be managed with whatever the cost is for the treatment. That would be a fantastic thing if we can figure out a way to make it effective. Insurance schemes are reasonable, but do not cover a lot of people, despite the fact that we have large populations. We also have a robust generic industry, generic drug industry, and that reduces the cost of a lot of cancer chemotherapies as well as targeted therapies, and hopefully immunotherapies when they come. These things theoretically should be factors that we can build on to build an ecosystem that, as was mentioned previously by Dr. Lokireddy, we don't reduce the quality of treatment, but at the same time give exceptionally good treatment to a large group of patients. And we would be the leaders if we got these things right. I think that's about all that I wanted to say to sum up the discussion. It was a fantastic discussion. I learned a lot from our panelists. And thank you so much for...
There are some raised hands for questions.
Sorry?
There are people, some people are raising hands for questions.
Okay, let's see. Where can you see?
On
Okay, there they are. Okay.
On the Q&A also, there are some questions.
Yes, I see them. What are the common symptoms individuals face initially in any type of cancer? Does anybody want to take it?
Yeah, but it depends on the, we always call it cancer signals, so, which is like is a bleeding from any orifices, like from the mouth, cough, or from the rectum while passing motions, or in the urine. That's one should investigate. Any lumps anywhere in the body. If there is any swelling which comes up, which is painless, specifically in the breast, must be investigated. And therefore, it is necessary that people who think that it's painless and they neglect should not be done that way. Any ulcer that does not heal. For example, if there's something in the mouth that causes, you can see it, that there is some, we call in Hindi jakham, or some ulcer, then it should be investigated immediately. Any woman who has got a bleeding per vagina in between the periods or after the periods have stopped or following the sexual intercourse, that must be investigated. These are the basic things which people should know. The commonest cancers in this country are in the women, breast and cervical cancer, there's a uterine cancer, and in men, oral and laryngopharynx, in other words, the upper aerodigestive tract and lung cancer. So if there is any cough which doesn't subside, it should be investigated. I think these are the very basic things people should know. And the best, of course, is annual checkup. If you are above the age of 35 or 40, you should go for annual checkup, whether it's a heart, blood pressure, diabetes, or cancer. That checkup is necessary. We send our cars for regular checkup, but we don't go and visit ourselves for checkups. I think it's one of the requirements is that you should have annual checkup, irrespective of symptoms.
Early diagnosis is key. And as Dr. Mehta said, it depends on the type of cancer you have. And different cancers present in different ways. Sometimes we cannot catch it early. In fact, for most cancers, we cannot catch them early. So awareness of cancers is an important thing.
For example, I'm in my 80s. So what I do is I go at least every 3 to 4 months to have a look at my sonography of the abdomen. There are certain cancers, for example, pancreatic cancer, kidney cancers, if early liver cancer, you will not get any symptom unless and until you go and have a look at your internal organs through a very cost-effective way is to look at through ultrasonography of the abdomen. So I think that part of it, people should realize that if you belong to a high risk or if you want to be 100% sure, at least basic thing you should get it done. You may not go for a very high investigation, but at least a sonography of the abdomen and pelvis would help you tremendously, even if you don't want to go for multiple consultations.
The next question is probably for Mr. Chandy. The question is, as far as I'm aware, proton therapy cost is 4 times higher in other countries. How is it different in India? Mr. Chandy?
Yeah, yes. The cost of treatment in US is $160,000, and in Europe it's around 70,000 euro. When you compare to India, it is close to $35,000. So we almost half the price of Europe and 1/3 of US. Same technology, same very good clinical outcomes. We're able to get matching outcomes with at a lower cost.
And the large volumes of patients also help. I mean, I think, we don't struggle for patients with that. And that is really what has to be one factor of what we do. Plus the fact that, people can only pay so much. So the next question is, can large 1,500 to 2,000 bed cancer hospitals be set up using out-of-the-box financing models used for building infrastructural projects like Cochin Airport or Konkan Railway? Similarly, can hospitals be set up using cooperative model, which is used for setting up banks? Who would like to take it? Would you like to take it, Dr. Lokireddy?
John, maybe from management would be better or experienced in answering this question.
Sure. Would you like to take it, John?
So if you look at our the past history, this sort of cooperative partnership has not really worked in the hospital divisions, because hospital, you need a good clinical team. The success is clinical team, is not infra. Infra is one part, CapEx is second part. The third important thing is a good clinical team. How will you integrate the clinical team? That is what is the main challenges. So that getting the infra or getting a CapEx is one part only. So 50% lies on the clinical team. So there where we feel still India has to go a long way.
I think that's a very good idea. This kind of hospitals, but it may not be 1,500 bedded hospital, but 100 bedded 15 hospitals, or maybe 200 bedded 7 hospitals as a cluster, where you could have a heart hospital, you could have a cancer hospital, you could have a bone marrow transplant group or organ transplant group. I think because that would reduce your equipment costs, your communication costs, your laboratory costs, because there will be large volumes that you will be creating of the investigations. I think that's one way of doing things. It's always better to have a cluster of hospitals together, which we have not yet gone onto that path. But like All India Institute of Medical Sciences, you have 1,000-bedded hospital, but they are difficult to manage. And these are public hospitals where it's a very indifferent treatment. Even patients, even if you treat them free, they're not happy. Because long waiting lists. For example, if you go to any hospital, like maybe Tata Memorial Hospital, you're waiting for 6 weeks, 8 weeks for your turn to come for surgery or treatment. I think patients can't afford to keep on waiting and waiting and waiting.
Time sensitiveness is extremely important.
Absolutely.
And I guess that's important for us to.
All our government hospitals and public hospitals, they're insensitive to human emotions and feelings.
Bureaucracy can stifle that.
Yeah, isn't that to do with the resources they have and the time scales they have, with the volumes and the structure? So yes, you have infrastructure, the buildings, the machines, the doctors, but you don't have the whole setup to run it. That's a big pitfall in many of the institutions, where you don't have all that resources and a running mechanism and streamlining that comes with a more of a business person, where there is a privatization, at least to a certain extent, to run in a structured manner and identify where there are waiting lists, how to come down on a basis.
Yeah. I think it's like the difference between a house and a home. Yes, you can build a hospital and you can build all the infrastructure you want, but until you can make it a home, a place where people can come in for their treatment and feel welcome, as well as the people who are treating feel that they're doing something effective, it remains to be seen how effective it will be.
It has to be value-based, values of cooperation, value for compassion, value of love and spirituality. I think it's very important because our treatments have to be value-based. Unless and until we put values in healthcare, whatever you do, it's not going to satisfy anybody. To be positive, to give them the best. Even doctors, for example, they all have a burnout. 40% of them show some signs of burnout. I think which means volumes that you have to change our ways of looking at life.
Sure. We have 2 more questions. Can we continue with them, or are you on a timeline?
Yeah. So
can
the
I drop
other,
in? Can I drop out because there was some other meet?
sure.
Sorry.
So the other
I had to
panel
drop out of
discussion
that.
also starts right now. So we
Okay.
can take these questions offline. We'll
Yes,
send them
I'll answer
and-
both of them. And, if my colleagues would like to answer them, that's fine too.
Great. All right.
Okay.
Thank you, Dr. Ashok Mehta. Thank you, Mr. John Chandy, Dr. Padmaja Lokireddy, and Dr. Mohan Menon. Truly an enlightening session on the future of cancer care and finance in India. Thank you, esteemed panelists, for this wonderful session.
Thank you very much for having us.
you.
Thank you, Impact
Bye.
Guru, for having us.